communication skills are learnable, teachable, practicable, measurable, and we should be thinking about those just like we think about how to learn how to auscultate the lungs or how to interpret a chest x-ray.
Okay, so today I am here joined by Dr. Thomase Leblanc. He's an oncologist, he's a certified and practicing palliative care specialist, and he's also a researcher in the whole patient communication and patient experience thing. Thank you so much for making the time to talk to us, first of all.
Happy to.
And my first question is kind of not medically related, but I have been looking through, your researches and what you do and what have you done. Do you ever have any time off, or do you sleep or something?
No, I actually require a lot of sleep to function. So I'm not one of these crazy people who just sleeps a few hours a night and then works all the time. It's difficult to find the right balance between work and other things, and like anyone, I struggle a lot with that. But I'm somebody who tries not to take a lot of work home, and personally I've kind of made some rules for myself and my family where I don't sit on the couch at night and work every night, and actually most nights I very intentionally don't do work at home, so that once I'm home, I'm home. And I travel a decent bit for conferences and speaking and research and grant review and things like that. So when I travel, I'm able to spend a little bit more time working, and I can work on the plane or maybe be working in a hotel room when I'm away from family. But really that's the only time when I'm spending a lot of effort outside of the actual office doing work. So for me, it's much more about not necessarily always working harder, because you burn out. You have to have other things you enjoy in life, and family is important, and hobbies are important. So you have to work smarter, not harder, and it's challenging to do. But that's what I try, and like anyone, I fail at it from time to time.
Yeah, of course. But that makes us human beings.
Yes, but for me, part of why I've been able to do a lot of things in my career so far has been due to having really amazing colleagues and amazing collaborators and fantastic mentors. So people who I've looked up to over the years, like Amy Abernathy and James Tulsky, and then other people even outside of my institution, Duke University, have been so generous with their expertise and projects and support. It has helped me just get a lot more done than I might otherwise have. And then we have a really amazing research team. So great nurses, people helping us with regulatory work when we submit studies to the IRB and all of these things that have to be done to do research.
But you don't have time to really do that.
Right, one person can't do it all. And it's the team is really important. Every person on the team plays a really important role, and without any one person, we wouldn't get it done. So I'm lucky to have a great team and great colleagues and collaborators for sure.
Now, talking about the team, usually palliative care is sort of done by members of a team. How would you describe actually palliative care? Because there are a lot of misconceptions, and usually students feel like it's just, oh, well, they're just talking, to the person dying, and I feel like it's way much more than that. So could you maybe explain what it actually means to you?
Yeah, this is such an important question, and over the years I have tried to describe it in different ways, and it's been a lot of trial and error and a lot of failures and stumbles. So I have come to really like the definition that CAPC has created, the Center to Advance Palliative Care, that they based upon actually talking with laypersons and doing public opinion polling and phone calls and just asking, what do you think palliative care is? Or describing pieces of it and saying, do you like this? Do you like that? Do you not like that? Does this scare you? Does this sound like something you would want as part of your care? And the definition that they put together on the basis of that research says that palliative care is specialized care for people and their families facing serious illness, and that it can be provided at any age and any stage in a serious illness, regardless of whether a person's getting treatment, whether they're expected to be cured, whether they might have a short life expectancy, anything in between. So in that way, it is an extra layer of support on top of standard medical care to improve the lived experience of illness when you have a serious illness. That's the way I like to think about it. And that's a little bit of a long definition, so I gave you a bunch of the components that I think are really important, but when I'm talking with patients and families, I often really focus on describing it as an extra layer of support to help them live better while I am focusing on their cancer treatment. And so that could be helping you with symptoms, helping you with quality of life, helping you to cope with a serious illness, helping you with mood, with family issues, whatever it might be. And usually that resonates with people. Who doesn't want extra help and an extra layer of support when you're struggling with something difficult, right?
Yeah, and you're actually coming from evidence-based supported, researches, yes. And many of them say that like the palliative support of a doctor or a nurse that is specialized in it actually makes the patient even less, let's say, it betters their symptoms and all of these things. How much of it do you think is really caused by what you do, and how much of it is just, someone cares, if you know what I mean?
Well, this is a really good question, and as I think you have kind of felt and experienced, we talked about this a little bit before we started the interview. There are many times in medicine and in healthcare where we aren't attending to the person as a person. And we're thinking about them as a disease, and we're thinking about the treatment, and we're looking at laboratory tests and all these other objective things. But were it not for the person, there would be no reason for any of this. So it's a little bit backwards and crazy that we sometimes forget to attend to the person. But the medical system is set up in most places such that there isn't always enough time or incentive or just room in everything else that you have to do to be able to do a good job at that. So I do think that part of how palliative care improves outcomes for patients and families is, as you suggest, due to someone just being there and attending to the patient as person and listening. But there is very much a skill and an art to doing it, to providing specialist palliative care and to doing it well. So there's evidence coming out now suggesting that a lot of the benefits of early integrated palliative care come from the facilitation of active coping in patients who have serious illness. So some of it is talking and listening, but there also is pretty clear evidence that attending to symptoms in a very rigorous, aggressive kind of a way is also part of what helps patients feel better. And that very much is specialized medical knowledge. So for example, if an oncologist is seeing a patient who's having significant pain or a lot of nausea related to their cancer or their cancer treatment, they will prescribe the standard things. And in cases where those standard things don't work and they're not sure what else to do, a palliative care specialist can come in and prescribe other things that the cancer care team might not be used to using for pain or for nausea or whatever the symptom and issue might be. Adjunctive kinds of therapies that you might add to the standard ones, or unusual kind of therapies that the oncologist may not even be aware can be helpful for managing those kinds of symptoms. And that improves how patients feel. So it's not only spending time and talking and attending to the person, although that's a huge part of it. It also is bringing this subspecialty expertise to the cancer care team.
Yeah, and because many of the people watching actually don't want to pursue their career in like palliative care, is there any advice that you would give to like any medical student out there, which no matter what specialty they choose, about like how to actually talk to the patient in order for them to feel safe, to kind of understand what's going on, but also not to, engage too much yourself and not burn yourself out?
Well, when I teach our medical students about this, my main point that I try to highlight is that, first of all, communication skills are learnable, teachable, practicable, measurable, and we should be thinking about those just like we think about how to learn how to auscultate the lungs or how to interpret a chest x-ray or a blood count. So it is a core skill of all physicians and all clinicians that one needs to be able to communicate with empathy and to communicate effectively and to be able to listen, to deliver information in sensitive but clear ways, to avoid all the medical jargon that we get so used to and we just start using it and we forget what it was like not to know. So that's an incredibly important lesson, I think, for all of us, and I really try to highlight that for students when I'm teaching. The other piece, though, that's just as important is we have to recognize that most of what actually makes us effective with patients and families in a clinical encounter and across a long-term relationship as we take care of them is communication. So most patients don't know much about where we have gone to school or other kinds of training, board certifications. They usually don't have an enormous medical knowledge, but they know how we make them feel when we talk to them. And so you can be the smartest person in the world and have been to all the most amazing schools and training programs and have perfect board scores and all of these other academic kind of objective accolades, and you can be an incredibly ineffective clinician if you can't engage meaningfully with the patient. And if they don't trust you, if they don't feel heard and understood, then they may not heed your advice. For example, they might not take their medications. They might not understand why they should. They might not recognize the long-term consequences. And even though you might know the right thing to do and you know all of the data about the health outcomes, you can't get them to actually do what you're recommending if you can't effectively communicate and understand them as a person. And that is a very underappreciated fact of medicine. It's really mostly the interpersonal. Certainly you have to know the diseases and know how to manage them, but that cannot replace poor communication. And really, I would venture that most patients and families would rather have a very empathic clinician treating them than the absolute most smartest, most amazing person in terms of book smarts, because that doesn't necessarily translate into better care if you can't communicate.
Yeah, earlier in your presentation you were talking about people not understanding percentages, which I found really interesting. I have not heard about that. So how to actually approach the patient? Let's say you have to, not that medical students would tell them the diagnoses, but one day we will eventually come to the time where we just sit in front of the patient and just have to tell them that they have an incurable illness. So how to actually explain to them what we need to do with them and what do actually... It's a really complex question.
This is a tough issue. So what I was talking about is a concept called numeracy. So it's like literacy, but applied to numbers. So the average American layperson is not functionally numerate, and it basically means that if you tell them you have a 20% chance of something, that they don't functionally understand really what that means in terms of how to apply it to their decision making or to their life. And that's a very, very basic numbers kind of an issue. It's not really even statistics. It's nothing complicated at all. But doctors tend to speak in this language, and we talk about percentages all the time. But the evidence shows that patients and families don't, on average, really understand those things. So there are some recommended ways of presenting numerical information that's more sensitive to this issue of poor numeracy. So one of the recommendations, for example, is to use a consistent denominator. So if you say 10%, then you really should be talking about 1 in 10, and then other numbers that you present, you don't later want to talk about 5 in 100. You try to keep a consistent denominator. Also to present the positive and the negative. So if you say there's a 1 in 10 chance of cure, that means if there are 10 people just like you, one of them will be cured with this treatment that we're talking about. That means that for every 10 people that I give this treatment to, 9 of them will not be cured. So you see, it's the same information, but you present the positive, you present the negative, you use the same denominator, and you don't use a percentage, you don't use a fraction. And evidence shows that that is linked with better understanding. And so decision aids that are meant to help people understand their situation and help them make a decision about a medical treatment are supposed to use these kinds of numeracy sensitive techniques for presentation. An even better way to do it is if you can actually use a graphical device, like what's called an icon array. And you may have seen these in lay press, like in the newspapers or magazine articles. And an example would be if you have a picture with 10 little pills, and the pills are different colors. Like when I said 1 in 10 earlier, maybe one of them is blue and the other 9 of them are orange. And so you can see, oh, this one is different than the others. You can go to websites and just put in numbers and generate one of those and have it on the screen or print it out and use that to talk with the patient about the numbers, and that can help to improve understanding. Of course, all of these things take time, but as best I can tell, most doctors have not been trained in how to do this and are not aware that numeracy is a very common challenge for patients and families. So when I'm delivering difficult news, bad news, or when I'm talking about treatments and prognosis and outcomes and things like this, it's obviously very emotional. It's difficult to do anyway, even separate from the numbers, but we usually have to talk numbers a little bit. My focus is always on the absolute basics. So, is this curable or not? Talking about that in a very, very simple way, and then asking whether they heard and understood that and what they're expecting. And then if we start talking about chances of this or chances of that, or if we talk about more complex concepts like a remission, what is a remission? That's different than a cure. Do patients even know what that means? We just use the word and we assume.
And no one really understands.
Yeah, there isn't understanding about many of these complex medical terms. I try to really break that down into very simple concepts and to deliver really short pieces of information and to stop frequently to check in. But the tendency we have, and this has been shown in several research studies, is to do what we call broadcasting, which is to just talk for like 20 minutes and dump a bunch of data on patients and families, often with a lot of jargon, and then say, okay, so which treatment would you like? Which one do you want? And we have this sense that the more that we can master this description of really complicated, confusing things and just dump all of this on patients, that we've done a better job. And what happens is there's no assessment of that patient and their needs, how they want to receive information, how they want to make decisions, how they want to talk about their care. And instead, the more we get specialized, the more we develop these little spiels, and we just deliver that the same way to every patient, and it doesn't meet many of their needs. So this is where we need to do a lot more research, but also need to spend a lot more time and energy thinking about how we actually deliver that news. But especially in medical school and even in further aspects of training like residencies and fellowships and so on, we appropriately are so focused on learning the medicine and learning what the statistics are and learning what the treatment paths are, that we forget that our job is also to translate that to something the patient can understand and use to make the best decision for them. So what we would call shared decision making. Largely, it's not really happening in the true spirit of that term, shared decision making, honestly.
I read somewhere on the internet that you had the opportunity to film an interview or a few interviews with doctors and patients and then talk to each of them separately in order to really know how they meant what they said and how they understood what the other said. What do you think are the most common miscommunication channels? Like, is it the hope? Is it the prognosis? Actually, you had the graphs in the presentations as well. What do doctors and patients see differently? What should we as doctors or medical students focus on in explaining what's really going to happen and what is happening?
Yeah. Well, the literature suggests, and what we've seen in some of these small studies we've done, is that we do talk with patients and families about these serious things. We talk about prognosis, but that we do it in ways that are not very accessible to them. Maybe, like I said, with complicated terms or numbers, whatever it might be. And it's different for every doctor, it's different for every patient and family. But the way we're doing it does not tend to translate into good understanding. And there are lots of reasons probably why that is, and we don't entirely understand it all. But the fact that many patients and families don't understand their prognosis very well when they have something like a serious cancer is not because we're not talking about it. Sometimes we don't talk about it. Sometimes we wait and we talk about it later. And there is some older evidence suggesting that we might avoid it unless the patients ask or bring it up. But that seems to have changed a lot. I think most oncologists are talking about these things with their patients. So the problem is most likely how they're talking about it, and then maybe when they're talking about it, and whether or not they're ever revisiting it, and assessing what the patients and families got out of those discussions. And so it's not enough just to say, we're going to talk about what this means for you and your life. We're going to talk about prognosis. You also have to then check in. What did you understand about this discussion? What are you going to tell your family when you get home tonight? And then the next time you see them and the time after that, just check in with them. And sometimes I just say something like, we talked about some really difficult things last time, and I just wanted to check in with you about how you're feeling about all this. How did discussions with your family go? What are you expecting now for the future after that conversation we had last time? And sometimes what you uncover is that they still harbor this significant misconception, and then you have to talk about it again. Or maybe you find they totally get it, they know exactly what's going on and what to expect, and maybe they're just having difficulty coping with that and living with that. And then you can focus on emotionally supporting them or figuring out who else they might need help from. Do you need to send them to a therapist, to a psychologist? Do you need to engage the palliative care team to help with coping and to provide more longitudinal support? The biggest mistake is in not asking, not checking back in, not being curious. And we're all just so busy and time pressured in the clinics especially that we sometimes just forget to do that.
And honestly, it kind of goes hand in hand with the treatment plan, because when you listen to the patient and what are actually their needs, what are their values, maybe someone decides that they don't really want to do the treatment because it has so many side effects that they actually just want to be at home and be with their family. And if the clinician doesn't give props to the patient about it, it actually may even change the whole treatment plan. So
yes,
that's pretty
true.
Interesting.
So we tend to view these conversations as one-time events, and that's wrong. They are longitudinal. The perceptions evolve. Of course, the situations evolve, but we often just talk about it at diagnosis, we give the treatment, and then we don't talk about these difficult things again until something else happens. A hospital stay, progression of disease, needing to switch treatment, needing to restart treatment, something like that. And probably that is not the right approach, and we're missing many opportunities to improve understanding and to just better support people as they live with serious things like cancers.
So you specialize actually in hematoonkology. I don't think I said that before, which is kind of really a heavy topic. Well, all of these that we are talking about are, but medicine is a great science about sad things. That's what I like to think of it as. But how do you, as a physician, we were kind of talking about it in the beginning, but how do you actually deal with all of those difficult situations, difficult life stories, etc., and still are able to do what you do, basically?
Yeah, this is one of the biggest challenges of taking care of people with serious illness. So I see many people who end up dying of their blood cancers, especially since I do a lot of acute leukemia care. Some people we cure, some people go to transplants and do well, and then some people suffer really awful things and end up dying of their disease or of their treatment or complications. And it's not for lack of them getting the best care there is from a wonderful team of people at my institution. It's just
you just never know.
You can't fix everything, you can't fix everyone, and you just don't know what the outcome is going to be. So it's hard not to take that personally and to think, what should I have done differently? What could I do better the next time? What should I have stopped? Should I have pushed more? There's a lot of these doubts that we all have, everyone who cares for people with serious illness, and especially cancers. But it's also true that many of us, or maybe most of us who do cancer care, we are in this business, and we do this kind of medicine because there's something so incredibly special about the patients and families. And so for me, what attracted me to oncology at the beginning was all of these amazingly positive things that I saw happen to people despite the tragedy of the diagnosis. And it's a testament to the human spirit, to people's resilience, and to the ways that we all adapt to new normals in life. And as much as I can't even imagine the awfulness of dealing with a diagnosis like that, and personally, in taking care of patients and families who are, I see positive impacts in their lives and transformations in ways that just make me want to be a part of that and to be a part of their story and to use whatever skills and knowledge that I have to try to make something better about that awful experience for them. So as much as I would love to fix it all the time, I can't. But there are other things that I can do. There's always something we can do to improve a person's life, even if we can't fix their disease. So that's what brought me to cancer care, and that's what keeps me there. It's the amazing patients and families and the relationships that you can have with them over time. It's a very amazing privilege, really, to be able to enter into people's lives during such a challenging time that really is often the worst thing that's ever happened to them in their life, and that may ever happen to them. So, but not letting the pain and suffering and the death and dying get you really down it's an enormous challenge. At the same time, though, the literature is pretty clear that one of the main sources of burnout is a failure to meaningfully connect with patients and families. And there's this
to treat them.
Yeah, there's this idea of kind of emotional exhaustion or a loss of empathy that happens as part of burnout or as a cause of burnout. This isn't something that I'm expert on, but just having followed some of the literature, since it's important for all of us who work in cancer care, the more meaningful connections you can have with patients and families, which happen through communication in large part, getting to know them and what's important to them, getting to know their families over time, that's actually what helps you maintain meaning in that practice. Because if you're just seeing 40 patients a day and you're rushed and running in and out and you don't have time to connect with the patient as a person, then it's just about the chemotherapy, it's about the mechanics, and it's not fulfilling. And then when bad outcomes happen, it's actually even more emotionally difficult and weighty, to the point where people kind of distance themselves and they become numb to it all. So as hard as it is to be present and to really connect more deeply with people and to care for them, because that means that it will hurt more when there's loss and when they don't do well, it's still, to me, is the way to actually not totally burn out doing this kind of work, because it makes it feel so tremendously meaningful, even when it doesn't go the way that you want it to. You feel like you have done something for them, even if it wasn't the outcome that you wanted.
I feel like as we grow older, or that's just the way I see it, we find out that there's no happiness in life because there's no single happy person that's always happy and that's just the way they are, and there are more of like the happy moments. And I think that what you just described is that you can actually enjoy and like really engage in those happy moments with the patients.
Yes.
So I think that's, and obviously when we get sick or just see sick people, it just makes us, you know, value our happiness and health and all of that more.
And that's the joy and privilege of practicing medicine, to be able to be part of those little happy moments in the middle of chaos and in the middle of something that's existentially challenging to a person and their well-being.
Kind of a different topic, but it just came into my head, and I'm not sure about the translation, but what is your opinion on euthanasia? Euthanasia, is it like the assisted suicide thing, which is always discussed about? How are your views of it as a palliative care specialist?
Yeah, this is such a challenging topic. I have really honestly been able to kind of skirt the issue a lot because in the state that I practice in the U.S., there is not any legal access to euthanasia of any form. And so there are several states in the U.S. where this is something that patients can access, and there's been some research done. But actually, the evidence that I have seen suggests that it's relatively rarely used. It's relatively infrequently used. And many people want the sense of control, knowing that they could have the ability to end their life when they want to on their own terms with a prescription from their physician. Going through and there's a formal process that you have to go through. There are kind of rules and regulations and guardrails in place basically to prevent abuse. But many patients don't fill the prescription or they don't take it. They just want to know that they can. They want to know that they are in control. And a big part of what's so difficult for many people when they face a cancer diagnosis is that there's this loss of control. Like all of a sudden, I have to go to all these appointments and these procedures, and I don't really have a choice. I have to take this chemo because otherwise I'm just going to do really poorly and die even faster, and I want to be around for my family. They sort of go into this tailspin, this downward spiral, and grasp for some semblance of control in their lives. At the end of life, sometimes that idea of when I could end things on my terms if I want is control that some people want. But in my practice, I have had very, very few people ever ask me about this. Now, maybe some of that is because it's not accessible in my state, but there are other things that are not accessible where I practice, like medical marijuana, but people still ask me about that, and they still talk about that. So I don't think that it's that people aren't asking just because of the laws. I think few people in the Southeast U.S. are particularly interested in doing it. I worry that much of the quest to make that a legal option for people has to do with the fact that we don't provide very good palliative and end-of-life care to many people with serious illness. And so I'm a firm believer that the overwhelming majority of people who might be thinking about that or who somebody thinks might need that kind of an option is probably not getting excellent palliative care. And if they were, they probably would feel differently about pursuing a euthanasia kind of an option. And I'm sure it's not 100%, and there are cases where you cannot manage a person's symptoms and they are suffering horribly and they are miserable, and there's this whole other topic of what's called terminal sedation. It's the idea of using higher doses of pain medications and sedatives because you literally cannot make that person comfortable. And so you are giving them enough medicine to make them comfortable, but it results in them no longer being conscious. And there's a lot of debate and uncertainty about whether that hastens death. It's not actually euthanasia, but it's part of this discussion and debate sometimes. But even then, I've seen so few cases where somebody has felt that was the only way to manage a person's suffering, that it just is not anywhere near the majority of what happens to people with serious illness. Certainly not the patients with cancer that I'm seeing and treating, or that my colleagues are seeing or treating. So I tend to steer these discussions more towards us needing to do better an earlier specialty palliative care as part of serious illness care, and that will probably address the vast majority of these kinds of discussions. And then when it's really, really bad and everything has been tried, maybe that's the time to talk about these even more weighty and serious and ethically concerning kinds of options like euthanasia.
Yeah, this is actually the first time I ever heard this opinion, and I feel like it makes so much sense. Coming back to the medical students, I feel
Yes.
like a lot of senior doctors or residents or just the practicing physicians all really often forget that once they were medical students and they didn't know stuff and they just were exploring the medical world and everything, and no one really asks did you are now a professor, you have received so many awards and you work at a really prestigious cancer center, etc. Coming back to your medical student years, have you ever felt like giving up or just this is not for me, this is too much, I don't know how do people do it? Has there ever been
sure.
times?
Absolutely. I hated being a pre-medical student, and the system is a little different in the U.S. You do 4 years of general university studies after high school, so basically age 18 to 22, and then you go to medical school for 4 years. Most programs are like that. There are some combined programs, but most of them are like that. So when you are in the general university studies, you have to take all of these pre-medical school courses. You take your chemistry, your physics, organic chemistry, some other things, basic biology, genetics, biochemistry, and those are on the entrance examination that you have to take to get into medical school. And there's a lot of pressure to do well on that exam, and that can determine what schools you get into or which ones will interview you. And so because of that, there's all of this competition and sort of cutthroat business in pre-medical school and in university years, but then it extends sometimes to medical school. And it really bothered me, and I always felt like there were so many people around me who were so much smarter, and they didn't have to work as hard, and they got better scores on their exams.
All the time.
And it's so frustrating to see that. I'm so glad that those things are behind me. And when I got through medical school and got to the point of working with patients, and it's no longer with your nose in the book and taking an exam and just remembering things to regurgitate them, but instead you have the context of the person and the disease, that's where for me things got a lot more fun and more collaborative and collegial, and it's just been so much more satisfying. I never thought, though, that I would be doing research like I do. I didn't think I liked research. I spent a few years doing different things in laboratories and pipetting things and doing things on computers, and I felt like it was too far removed from something that I thought would actually have a meaningful impact on a person. It was going to take way too long from this pipetting thing to turn into something like a drug that would help someone, and it just was too slow and too abstract for me. And it wasn't until I found the thing that I was really passionate about that I want to change in the world. And really it's these issues of the patient experience and palliative care and communication and dealing with symptoms and coping and all of these things that often are pushed to the side and forgotten in medicine. Once I found those things and met mentors who taught me that you can actually study those things, and then you can develop interventions to improve those things. You can teach about it. You can make that the focus of a research career and a clinical career and a faculty career. That's when everything for me clicked, and it's just been fun and amazing ever since then. So, I never thought I would write all these papers and things. And when I was a student, if I had to get up and talk in front of 5 people, I would have a heart rate of 150 and be worried about passing out and turning beet red and all these things. It's none of this has come naturally to me at all. And you learn, you push yourself, you learn from your colleagues. But the difficult things about being a student, you get through it and they get easier. And you just have to figure out how to find the silver lining, as we say. What's the light in the cloudy day, in the difficult situation? How do you get through that? And maybe that's with friends or colleagues, maybe it's family, maybe it's a hobby, but you have to figure out some way to persevere, because the tremendous joys and privileges of practicing medicine are so close, but you're just not quite there yet when you're still in medical school, and you get these little tastes of it, and you start doing your clinical rotations, and you finally start to work with patients and families, and you get this sense of what it might be like. You just can't do as much of it yet, but you start to try that on and practice, try it on for size. That's when it really gets fun and interesting. And a lot of the stupid things like the exams and the applications, that stuff ends up mostly behind you. So there is light at the end of the tunnel.
That's what we all need to
and you
repeat to ourselves.
Find the little joys in it for now, and the people who you aspire to be like. And nobody's perfect, but you find little pieces of things in the faculty and the teachers and your colleagues that you want to emulate, and you kind of form this idea of your future
just
best
like
self,
me
and you work
sitting
towards
here
that.
with you.
Well, that's kind of you to say, but hopefully there's something positive in all this that you can take and say, that's something I want to try to do, this little piece of something that that Tom does, and you figure out what that looks like for you and who you want to be. I still feel like I'm trying to figure out who I want to be when I grow up, but this is lifelong learning in medicine, and we're all learners and we're all teachers all at the same time. We all need mentors, and we're all mentoring others. It's just like this great circle of life in medicine, and it's for me part of what makes it just the most amazing career that never gets boring and never gets old, because there's always something new and different that you can do.
Yeah.
So I hope that's encouraging.
Yeah, definitely it is. And actually my second to last question is basically what you just said, but in a different way. In the Czech Republic, we go to medical school straight after high school, and we study for 6 years, and the first 3 years are really just theoretical. You don't see a patient, you don't feel like you're studying medicine pretty often, and then after those 3 years you get into the clinical rotations. So what advice would you, or like what can actually the younger students in the first 3 years, which are not even meeting the patients yet, what can they like start maybe thinking about, or what would you encourage them to prepare themselves for the future clinical things?
This is challenging. In the U.S., it's similar in that we do 4 years of undergraduate, and then usually the first 2 years of medical school has very little patient contact and engagement. That's changing a lot in the U.S. There's increasingly focus on getting you at least in front of patients and interacting and observing right from the first year of medical school. So really, though, that's basically year 5 out of 6 for you. So we're in the U.S. Actually, we're doing it even later, perhaps than you are here. I encourage people to volunteer and to figure out a way to get into the clinical environment where they can just start experiencing that. And most of us at that age have not been patients ourselves. And maybe we've had or if we have, it hasn't been in a really serious illness kind of a way. Or maybe we've had a family member get really sick, but still not that much exposure usually to medicine. The more you can see that and experience it and try to put yourself in the patient's shoes and see what they go through, and to do that actually before you get indoctrinated in all the jargon and start thinking about all the pathophysiology and the drugs and everything, that can, I think, set a really solid foundation upon which to become a more empathic communicator, a more patient-centered doctor, a more caring, compassionate clinician, because you will have seen and felt that before you really know much about medicine. And then the challenge is to not forget. And that is the biggest challenge that we all face. We forget what it's like not to know words like thrombocytopenia. and we start using them with patients, and they don't want to feel stupid. They're not going to say, "What's that? What do you mean?" Most people just won't, and they'll just sit there and smile, and they'll have no idea what you're talking about. How do we always remember what it was like not to know, and then translate all of these complicated medical things to the person and the patient and family, remembering them as the person, not as the disease. Seeing patients earlier before you know much, I think, is very helpful. I don't know if that's allowed in your system.
Actually, no one really cares about you. But if you just ask, you can always just stand there and see, and maybe like help the nurses. And not a lot of people know about this opportunity, but it is actually pretty possible.
So you can shadow and kind of follow around. And
it's really,
that's what I encourage undergraduate students in the U.S. to do if they're thinking about applying to medical school. A lot of schools want to see that you've had some healthcare experience, research, shadowing. Some people will work as an EMT, like the person on an ambulance who provides emergency medical treatment. Some sort of exposure so that you really know what you're getting into, and then you can just kind of be a sponge and absorb everything and be a fly on the wall.
I'm all about a sponginess.
And like you said, getting to know the nurses and what they do and what their practice is like. Actually, to this day, nobody has ever taught me really what nurses do, how they work, what their training is like. I've had to learn all of these things on my own, and through my wife, who's an intensive care unit nurse. And it wasn't until we met that I really started to learn things about nursing practice, and most importantly, learning about what the nurses get frustrated with from the physicians, and how there are often actually conflicts and difficult interactions with physicians, and sometimes mistreatment or poor communication that can compromise the patient's care. And we in the U.S. Tend to just not talk that much about it. It's not part of standard medical school curricula that I have seen, but there is an increasing push towards this idea of interprofessional education. And the idea is doctors and nurses and physical therapists, social workers, psychologists, all these different kinds of people in the medical environment need to actually train with each other and learn what each other bring to the team that helps the patient and family. I had very little of that in my training, and it's a handicap.
Yeah,
it really is.
It's what you see when you shadow or when you are not in the situation, which is only the thing. This is the thing that you see from the distance.
And the less you know, I think the more curious you are. And so when you're there and you're the fly on the wall and you don't know anything about these diseases, and you just ask questions, and people will tell you, and they will teach you, and not losing that curiosity is really important as well. And it extends to relationship with the patient and family, just asking, being curious about their experience and what they need from you, what they're thinking, what they're feeling, what they're going through. One of the biggest mistakes we make is just assuming we know what's going on and not asking, not being curious.
So that brings us to the beginning, which you were actually talking about, the curiosity. My last question for you, I always do this at the end of those interviews or like podcasts or talks, and it's actually really funny to see the reaction. There's two groups of people. One of them just starts laughing nervously and they just don't really know.
I'm already doing it and I don't have the question.
Well, so just wait for the question. And the other group is just like, oh yeah, this is my time to shine, and they just start, talking a lot. So it doesn't really anything to do with medicine, but I'm always curious about one thing, and I know it's pretty difficult just to pick one thing that you have learned in life that was the one that you would really want to share with the world, basically.
Well, honestly, for me, the most important life lesson ties back to most of what I've been talking about with you. And it is the idea that how you interact with people and how you make them feel is really the primary determinant of whether you will be successful in whatever you do or whatever you're trying to do. And I didn't understand and appreciate this for a really long time, especially outside of patient care or relationships. So, for example, in the workplace, if you are managing people in a business kind of a setting, you're managing a team of people. If you are an effective leader, there are certain things that you are probably going to do, and sometimes it's conscious, sometimes it's unconscious, but you will get to know people, not as the person who fills out this form for me when I need it. So who are you? And I know your name, but what's important to you? And who do you want to be? How do you want to grow? How can I help you be your best self, be the person you want to be? What's the next step for you? What's your value added here? What things do you struggle with? What do you want to learn more? How can I help develop you as a person? And then in turn to be curious about what you could do better. It's all communication and interpersonal and perception of respect and value. So translating that kind of idea and life lesson into everything that all of us do, to me, is the thing that I'm always struggling with, but also finally realized in recent years that needs to be the main focus of how I do anything that I do, how I interact with people. And it comes back to what I said earlier, that how a person feels when you interact with them is going to determine how effective you are as a physician. The same thing is true in life, in how you are effective as a partner, a spouse, a boss, a colleague, a friend. It sounds maybe a little bit trite and simple, but doing it well, being aware of it. When I say this, somebody felt that. It requires tremendous emotional intelligence, or what some people call EQ, not IQ, it's EQ. And some people just don't have that, and they're not going to have it. But you can learn it too. You can train yourself to pay more attention to it. Empathic communication is a lot about that in medicine. We can apply it to every aspect of our lives too, really. So hopefully that's a useful answer for people.
Definitely. And we have also learned that you belong in the second group, which just takes the opportunity.
I hope so, anyway.
Yeah, thank you really much.
You're welcome.
I think this was really helpful, not just for me.
Great.
Well, I hope. I wish you a lot of luck with all that you do.
Thank you, and
maybe,
likewise.
Yeah, thank you.